PNW. We're Comcast Pacific Northwest region, and we're expanding in Oregon and Washington. We're bringing Xfinity and Comcast Business to more communities, connecting you and your beloved neighborhood shop to the moments that matter most. Whether it's your favorite gym or sweet spot, your child's learning, or where our employee volunteers gather, we're showing up as any good neighbor would, and we don't come empty-handed. We learned that lesson way back in 1963 when our family-run company launched a dream in rural America. Now, we're returning to our roots. We're building a faster, more reliable network, laying thousands of new miles of fiber lines to launch the Internet of tomorrow. From the Canadian border down through the Willamette Valley and in eastern Washington, we're here to serve you in the PNW.
Good evening, everybody, and welcome to our May Civic Cocktail. Make some noise. My name is Alicia Crank. I'm the executive director here at Seattle City Club. It is so wonderful to see all of you tonight. I will say, every Civic cocktail is supposed to be my favorite, and they are, but this one definitely is one that I have been looking forward to, that hits home for me personally, professionally, and it touches all of us. One of our speakers that we're going to see tonight, he said something to me at the early part of the pandemic that has stuck with me to this day. And he says, everyone has a mental health. And that sat with me because I think there's such a stigma that when we talk about mental health, that it's automatically a bad thing. And we really need to get away from that line of thinking. We all have a physical health, and we all have a mental health. So I am looking forward to this conversation tonight, to learning from our panelists tonight, thanking them for taking time out of their crazy busy schedules on such a beautiful day to be here with us. And I thank you all for being here as well. I want to thank our partner in this, Comcast. Without them, we would not be able to have this Civic cocktail, so thank you, Comcast. Thank you. To our production team here at Bermudez Media, thank you for always making me look decent. And to the Collective Seattle, an amazing host for allowing us to be in this space and just having a great time connecting with one another. So please give them all a round of applause. So as you may know, it is Mental Health Awareness Month, so that's why we wanted to lean into this topic. And we're going to talk about it on two different levels. So our first panel that you're getting ready to hear is going to be talking about it from the governmental/regional aspect. And then the second panel will really talk about mental health as it pertains to youth or to BIPOC or to marginalized communities. So there is a lot to learn tonight. I'm looking forward to learning along with you and connecting with all of you. So with that, I am going to hand things over to our first moderator of the evening, Mr. Will James, who will tell you more about himself, and then we'll learn more about our panelists as well. So thank you.
Thanks everyone for being here. I'm very, very excited to speak with our panelists tonight. I'm a local journalist. I just spent the past few months working on a narrative podcast called Lost Patients, which seeks to really help explain, through our reporting with KUOW Public Radio and the Seattle Times, a phenomenon that we see every day in cities like Seattle, which is somebody in mental distress, in what we sometimes somewhat euphemistically call a crisis, out in public on the streets, and helping orient people with sort of a common framework to talk about that issue. I want to start by asking all three of you to just briefly introduce yourselves and just explain your relationship to this issue, mental health. Can we start with Lauren?
Sure. Good evening, everyone. Thank you so much for the opportunity to be here. So my name is Lauren Davis. I am a state lawmaker. I represent the 32nd Legislative District, which straddles the Northwest King County, Southwest Snohomish County line, shoreline, Northwest Seattle. Whoop, whoop, we got 32nd. Mount Lake Terrace, Edmonds, and Linwood. I am, my relationship to this, the way I accidentally became a lawmaker was because I was advocating to the legislature about this particular topic. This is the reason I ran for office. I do this work outside of the legislature. I was the founding executive director of a nonprofit called the Washington Recovery Alliance, and for me this work always will be deeply personal. I am the adult child of a parent with severe substance use disorder. I lost my best friend a year ago in 15 days related to substance use disorder. I used to work in suicide prevention. I myself identify as a person in recovery from mental health challenges, so very glad to be here.
I feel like I need to move up north. It sounds like fun up there. Yeah, right? Yeah. Yeah, so I'm Amy Smith. I am the acting chief of the Seattle Care Department, which is Seattle's third public safety department. It has been set up. It is a thing. I have oversight of Seattle 911 and then diversified response. So what that means is if a call comes into 911 that does not require law enforcement, a gun and a badge, is not medical, is not a fire, who do you send? And about half the calls in this country fall into that middle category. So I am very grateful to the mayor, to Bruce Harrell. He recruited me. I'm career nonprofit. I'm not a dissimilar background to Lauren's. And I arrived about a year ago and just got really captured right away, sitting in 911, understanding what first response looks like, the systems gaps. I knew some of them because, again, I've been around child welfare my whole career in human services, but they are profound right now. We don't have a system set up to receive people in a way that they can predictably sustain recovery. And so that is why I talk fast and why I'm happy to be here. Very grateful for the platform.
Hi, my name is Tom Kozaczynski. I'm the Chief Advancement Officer at Compass Health. I've been at Compass now for 11 years. My role there primarily focuses on fundraising and advocacy work through our communications work. For those who are unfamiliar with Compass Health, we're one of the state's largest nonprofit mental health providers, serving primarily individuals on Medicaid in Snohomish, Skagit, Whatcom, Island, and San Juan counties. Serve about 12,000 individuals with a full continuum of care. And we have some really, really exciting things going on at Compass right now with a capital project in Everett to replace one of our largest facilities with a facility that will be custom made for our highest acuity patients. And then also here to talk about some advocacy work we're doing around systems change, particularly around the Certified Community Behavioral Health Center model, which is a really key component to what we're trying to work on at Compass Health right now to ensure that we have really the financial resources to do the really challenging work that we do. And I'm sure that will come up at some point, but I'm excited to talk about it. So thank you for having me.
Thank you all. So I want to start by sort of orienting us in this conversation. The words mental health are fantastically vague, and we use those words to mean so many different things. But because of the experiences that the three of you bring to bear, I want to work with a definition of mental health that we commonly use in the political and civic realm. When we talk about mental health in those contexts, we're usually talking about something kind of specific, and we're talking about the experience of moving through a city like Seattle and encountering a person behaving in a way we don't understand. This is a daily experience for a lot of us. And when we see someone in that situation, when we use the term in crisis, which is also an incredibly vague term, Lauren, I wonder if you can help us understand more specifically some of the things that might be going on with that person.
Sure, so I'll try to bucket it into a couple different categories and just non-exhaustive list. One that comes to mind, probably the more classic presentation, would be perhaps a person who is living with a psychotic disorder, so they are having perhaps auditory hallucinations, and they are responding to those auditory hallucinations, which for them are incredibly real, or they're responding to delusions. And so, and again, those can incite fear, and who among us would not be fearful if we heard a voice telling us to do something? That's called a command auditory hallucination. If we saw something, if we saw people following us, it would be terrifying and paralyzing. And so responding to that, we can have individuals experiencing suicidal crises. And what's important to remember about the experience of suicidality is that, number one, it's never about wanting to die. It's about escape and escape from pain. But number two, there's always an incredible amount of ambivalence. So people are teeter-tottering, and they've actually looked at data to find that even individuals who survive nearly fatal attempts, they actually change their mind, while jumping from a bridge or while there's this teeter-totter always about life or death constantly. And we find people in crisis calling 911 in those types of experiences. And then substance use disorder crises. You can have a person responding, they're intoxicated, under the influence, responding, psychostimulants, methamphetamine, cocaine, people who are falling out, call it, like nodding off, opioids often, alcohol as well, depressant drugs, or you could have somebody experiencing acute withdrawal from substances, which is another form of crisis call.
Right, thank you. And Amy, you're in charge of a relatively new department within the city that is responding to some of these crises. I wonder if there's anything you would add to Lauren's description, what your team is encountering out in the world in Seattle.
Yeah, it's fascinating to realize how often we're making assumptions that are just wrong. So I was I'm kind of an academic right away, trying to understand call types. What does this mean? Person down, what does this mean? It means everything. It means everything. So crisis, I use that term. It's so many things, unique things. We respond to people. I look at the end of the day at the narrative, what the care team responded to, what it turned out to be. Often we called it a trespass. It wasn't a trespass. It was somebody under the influence who wandered into a yard, right? And so that is a misclassification. When I hear trespass, I think, somebody intends to break and enter or something like that. Nope, it's not that. We've responded to a woman who was, weeping outside of a supportive housing environment. Her partner had just died after 30 years. Profound loss and crisis. It's all different things. And so that's what I'm trying to stress, is that there's so much variety, complexity, there's nuance, and the thing that we need to do is spend enough time with someone to understand what is going on. Do we need a clinical diagnosis here, right? Do we need a medical diagnosis? I have so many stories at this point. Last year, somebody we thought had multiple personality disorder or something like that. It turned out they had a brain tumor. Somebody at Harborview finally took a minute, right? Yeah, and so it's interesting when you think about neuroscience, cognitive science. We used to just be behaviorists. We would just look at a behavior and then make an assumption, but we should not do that anymore.
Thank you. Tom, I want to ask you a question. You brought up funding in your introduction. Your organization, Compass, recently announced some layoffs and the closure of an outpatient therapy program. Your organization is not alone. It just seems really striking that at this moment, when this issue is front and center in our politics, in our lives, the organizations that we task with providing this care all seem to be really struggling to fund themselves, to staff, and to staff up their programs. Can you help us understand what are some of the pressures that your organizations are under right now?
Yeah, let me start off by saying that obviously changes in our workforce are extremely challenging, and it's not anything that we take lightly or anything that we want to do. But the realities are of our current funding system in Washington State, which is heavily reliant, particularly in the programs that you mentioned, on fee-for-service, which is an antiquated model, particularly when you're talking about individuals that have multiple barriers to entry to care, be that food insecurity, housing insecurity, as simple as how do you get to your appointment. A fee-for-service model actually requires that person to be sitting in the chair and receiving service, because our payers won't pay us if they're not actually there, right? That is a very typical payment model in the physical healthcare model. But if you're talking about individuals on Medicaid that have all these other barriers to entry, then all of a sudden you can see some of the issues that come up in that model. So I mentioned CCBHC, Certified Community Behavioral Health Center model, that we are actively trying to implement in this state. If you're familiar with federally qualified health centers, FQHCs, it's a very similar type of payment system, which is called prospective payment, which means we work with our payers to actually come up with a payment system and a payment model that projects out our yearly expenses based on the type of service that we're providing. So we are actually being paid appropriately for the type of work that we're doing, which then will allow us to hire and retain people, pay them better salaries, make this a career that people can have a living wage in, right? And gives us the tools and resources necessary on a financial basis to actually provide all the services comprehensively. So the CCBHC model is so critical for the future. It also, I will mention, then adds substance use disorder and physical health care into the mix of work that CCBHC providers provide, which it sounds like a lot of folks are familiar with the fact that people who have mental health issues oftentimes have co-occurring disorders with substance use and physical health care. And so if Compass Health is their home, their healthcare home, their first stop in their healthcare journey, we ought to be providing those services too. But under the current system, it's not possible. With CCBHC, certainly is a possibility for Compass Health in the future.
Yeah, it sounds like you're talking about finally aligning the way we fund this care with the realities of the patients and the clients that you're working with, which has taken a while, I guess.
Yes, and we also contract with 5 separate payers, all with their own agreements with Compass Health on top of it, right? So when you look at the complexities of the funding system, it is incredibly complex. You can be serving the same type of patient under a different plan that is paid differently currently, right? So that doesn't allow us to forecast easily for what a traditional fiscal year would have us do. So
yeah, I want to ask each of you a question. I'll start with Amy. You all are deeply immersed in this issue of mental health care. You also are all living in the area and bearing witness to the discourse we're all having about mental health care in our politics, sometimes on Facebook and Nextdoor and social media. What is a difference, a major difference, between your experience working inside this system and the discourse that you see happening outside among the rest of us?
One of the things I like to address is how much consensus there is on the front lines of provision. When you get out with providers, whether I'm talking about housing or recovery or mental health, there's mutual respect and support. And it is not accurate, that it's divisive and everybody's seeking a perfect solution. And I hear that a lot. I hear people arguing about housing first and arguing about harm reduction, arguing about mental health. And I don't know where that's coming from. I kind of actually stay out of, I don't know what's out there, I really don't. But I learn from the questions I get asked. When we talk about mental health, we often are also talking about substance use disorder. People ask me which comes first. I usually say it doesn't matter. I want to help the person. We can figure that out as we go. But we need to get people help. We need to agree that recovery is possible. There is always a way. Someone can be better a year from now than they are today, always. And we need to commit to that and work together.
Tom, what about you? Working within Compass Health, when you talk to people in among your family, your friends, people you meet, what are some of the differences between the discourse out in the world and your experience of this issue?
Yeah, great question. And I sort of have the benefit of not only being internal in Compass, but then also interacting with a lot of people in the course of my work. I think, particularly because Compass Health serves such a large part of the state, Everett being a very urban area out to Friday Harbor, which is, very rural. The needs, even though the flavors are sort of the same, can be different based on the community we're serving. And so I think front and center for us right now, particularly with the new facility that we're building in Everett, which will be 70,000 square feet for our highest acuity programs, I think there's a real realization of the intersection between the more traditional healthcare model, particularly hospital systems, emergency rooms, and agencies like Compass Health, where I think there's a realization that we play a critical role in that physical healthcare model, where a lot of folks, you just kind of assume people show up to the ER. Well, that's true, of course, for people in a medical crisis, but if there's a facility like Compass Health that has an emergency and evaluation and treatment center like we will have, 16 beds, or a triage center like we will have in this new facility, we should be partnering in the community to make sure that the most appropriate level of care is provided to the individuals that we're interacting with. And I feel like some of that has changed. The discourse has changed. I think people have really started to realize that mental health is a critical part of the overall healthcare system, and that has taken some time for sure. There's still a stigma, for no doubt, but I think that is slowly starting to change a little bit, at least in the conversations that I'm having.
Lauren, you're a state lawmaker. You cannot avoid the discourse if you wanted to. What are some of the gaps in understanding that you experience?
Sure. So let me begin by answering your question with a quick story. So last spring, so picture Highway 18 in the morning. There is a woman on the side of the road. She is bloodied and she is screaming for help. And dozens and dozens and dozens of cars pass by. Nobody stops. Eventually, a sheriff's deputy in plain clothes who is driving to a training stops and has curiosity, inquires with the woman, finds out that she was in a vehicle that tumbled down an embankment. It's now on fire, and there's somebody trapped inside. And deputy goes down, finds person trapped inside, still on fire, pulls him out of the car. That person is a dear friend of mine, a close loved one, and is alive today. But I think about all the people who passed by, right, who were terrified, too busy, were in this place of othering, this place of lack of connection, of dehumanization. And we see that all the time. I have a colleague in the legislature who used to say, it's hard to hate up close, but we're missing that. What I see on the ground is profound suffering, and to have walked with somebody living with behavioral health challenges, you can't help but be changed by that suffering. I switched careers because of being moved by that suffering. I'm in public office because of being moved by that suffering. But people don't allow themselves to bear witness to that suffering. And it is, and we see that every time we try to cite a behavioral health facility in any community, including the district I represent. God forbid we tried to cite a methadone facility for people seeking treatment, life-saving treatment for a fatal disease, and out came the protesters and the signs, and that is the disconnect. When the real poverty of people experiencing homelessness and mental illness and substance use disorder is not a material poverty, it's a relational poverty. And shame is not the cure for addiction, it's the cause. And we've got to unwind that.
Lauren and I just became best friends. You were all here when it happened. Yeah.
Before we open it up to the audience, I wanted to ask one round of questions again to all of you. Many years ago, we had a mental health care system in this country where states like Washington oversaw big asylums with their own armies of psychiatrists and nurses, and people with the most serious mental illnesses found themselves locked away there, sometimes for their whole lives. We shut that down, and we purported to build something in its place, community care. That is the system that you all work in or adjacent to right now. It was supposed to replace the asylum model. The reality of it is that many people with the most serious mental illnesses and substance use disorders end up cycling between emergency room, jail, homelessness, prison, jail, emergency room, brief psychiatric holds. From your vantage point, what is breaking down? What is missing that is causing that to happen? I'll start with you, Tom.
Well, I think one of the areas that Compass Health realized that we needed to invest in was housing, and so part of the project that part of it's actually already complete. It's called Andy's Place. It's 82 units of supportive housing in Everett. It's the first phase of the redevelopment project that I've mentioned. Well, if you think about the individuals that are cycling, as you mentioned, you cannot provide any sort of service that is going to be effective to those individuals if they don't have some of their basic needs met. And one of those basic needs is a roof over their head and somewhere that's safe. And so with Andy's Place in particular, because in Snohomish County there's a coordinated entry system, which means the county actually runs the list of homeless individuals based on need. Compass Health in this case took numbers 1 to 82, right? So these are individuals with chronic and persistent mental health issues, chronic and persistent homelessness. And when you are able, and for sure, when you congregate individuals in a setting, there are challenges. But the fact of the matter is we are able to provide services or work with our partners to provide services for individuals to finally start getting some of that care and connect them to natural supports. So in this system that's not, not a state-run institution, we know that if individuals are placed in the communities where they have natural supports, they are going to be more successful. And so I think for Compass, when we had the choice of, well, do we invest in housing as part of the holistic nature of our work or not, we decided to, and that has shown to be quite positive for those individuals you're mentioning.
Gotcha. Housing, having somewhere to put someone, having somewhere for someone to live while they receive care. Lauren, what do you see breaking down or missing?
Yes, I would say 3 chief things. Not all, but many of the folks, the population we're talking about tonight, are in need of intensive case management. Our system is wildly difficult to navigate. There's the sort of benefits piece, the DSHS aspect, there's the housing piece, there's the employment or education pathways piece, there's the behavioral health piece, the physical health care piece. It is, you need a PhD plus an act of God to figure out how to do all that. And so you really do need that guide. And the part of I'll just critique the state here and local government too. We keep throwing out a ton of different boutique programs that serve slightly different populations. To name a number, PACT, HOST, WISE, LEAD. They're all providing, the golden thread is intensive case management. So, but a person needs one person to be able to figure out that system for them and to stick with them, and we need to pay them well enough so they don't turn over every 6 months after they, so that's the kind of, I think we need to also have more of a uniform system instead of creating a dime a dozen boutique programs to serve niche populations. But another place we fall down is recovery support services. So recovery doesn't happen in treatment, it happens in community. And we fail miserably on everything that happens post-treatment, particularly post-inpatient. And the reason the state has never invested, until 3 years ago, we didn't hardly invested a dime in recovery support services. This is, housing, employment supports, hope, purpose, meaning, structure, routine, all the things that keep diseases in remission. We didn't invest in it because you can't bill insurance, but you can bill insurance for treatment, and we pay 10 cents and the feds pay 90, so that's a sick deal. So we just pay for treatment over and over. So that's that piece. And then finally, I can't help but mention the issues around civil commitment and our threshold for involuntary treatment, candidly just being where it's among the highest in the nation. It's incredibly difficult to access, and so we wait until people are so acutely ill. And when, particularly with psychosis, the longer the brain is psychotic, the harder it is for a person to walk that back.
Right. And Amy, your team is encountering some of these people when they are at that low point of psychosis out in public, when they're in crisis. What do you see is missing?
Yeah, I would just confirm everything that was just said. That is exactly it. The system is set up and designed to fail people at epidemic rates right now. We do wait until somebody is so badly decompensated before we can intervene at all. And I agree, involuntary treatment, I'm talking to Lisa Mannion about that, is going statewide because it is the most prohibitive in the state on the premise that, people need to self-determine. That to me just looks like bootstraps thinking. I'm gonna wait till you make a different choice and get help. Nope, That is not the nature of severe mental illness or severe substance use disorder. You know, we have got to intervene. We've got to interrupt the behavior. Some people do need inpatient treatment, and this country has a history of swinging wildly. Asylums are bad. Shut them all down. You know, they were bad. And that's what we do. I think we get scared when we have new information about what's not working and respond, but we never invested. Since the 60s, we did not invest appropriately in prevention. And now here we are, 70 years later, and here we are, and it is predictable. So, you know, I'm just always recommending that we need to, as a state, come together and invest appropriately at the first sign of trouble. It will save us money. I know what I'm spending in public safety. Yeah.
Thank you. I think we're going to open it up to some questions from the audience now.
Hi. Thank you for coming. I have a quick question at the state level. What legislation are you looking at to address some of these problems that you've identified, and I think everybody in the room agrees with? And then also at a city level, what legislation is being considered? Thank you.
Yeah, I can start with the state piece. So we've actually done a lot. By no means are we done or complete, but we have, just to give you a quick flavor, so the Healthcare Authority implements a lot of our behavioral health programs, and 6 years ago and before that, they would have less than 10 new behavioral health investments per year. About 5 years ago, they had 47, and then it was 74, and then it was 96, and so we have funneled a huge amount of money, and I would say half the battle is actually not looking forwards but looking backwards and making sure we've passed a mammoth amount of bills, sweeping legislation, but legislation doesn't always get implemented well or consistent with legislative intent, and it is actually a huge amount of work to be involved in the day-to-day and the monitoring of that. So, we were the first state to pass comprehensive 988 legislation and then follow-up legislation around crisis receiving facilities. We've got the call center hubs. We've got the mobile crisis response teams. We've invested. We're the beneficiary of a lot of opioid settlement dollars, have invested those. One of the things that I'm going to be convening this interim is a conversation about what I just mentioned, which is how do you come up with some sort of mechanism to make sure that people are identified and sort of attached to a program with a consistent case manager as they navigate through the web. Continued conversations around responding to the fentanyl crisis specifically, and that drug is just so unique and has really shattered our medical systems, our public safety systems, and how do we respond uniquely in response to that very potent drug.
Yeah, the state did get a lot done, even in this last short session I was down. Major steps forward, liability protections for mobile crisis responders, 911, 988. We got to invest in that point of first contact and understand how to divert back and forth. In the city, what I'm doing that I think is meaningful is I'm just saying public safety is one team. We're all one team. We need to train up together, skill up together, know one another, and be able to coordinate our records. We say high utilizers. Who are these folks who are chronically in crisis? And again, I'm sort of a data scientist, and I feel like if I know what calls are going to come in from what location, why not get out there ahead of them? Right? Why not figure out what's going on, just invest in more case management, things like that. So I will continue to make the financial case for doing what is the morally right thing. Yeah.
My name's Ann Allen. Lauren, it's lovely to see you develop and evolve into this lovely advocate. Thank you for everything you've done at the legislative level. Really, thank you. The next step of implementing things is really funding. And I have become a DCR, a designated crisis responder. And I took a $20 an hour pay cut to do that. $20 an hour pay cut to do that. Because I'm a committed person to our community. I just wanted you to know. So please fund us.
Yeah, I'm going to respond to that too. I think one of the thing that I'm the most proud of last year was that I got these new first responders classified and compensated as such. I think it's probably the first social worker job that gets paid. It is not $20 an hour. It's 3 times that. To do this work, they're working 3 12-hour shifts, well-being supports. Let's acknowledge the work. And we need to do the same thing for the DCRs. We need to invest in social work and case management.
And for agencies like Compass Health, with the exception of Snohomish County, where we actually run the DCR programs in our other 4 counties, It all goes back to the CCBHC model. I'm going to keep saying it because as an agency that then also has DCRs employed to work for the county and for the community, same issue, right? If we can't have a prospective payment model that actually forecasts how much it costs to do that critical work in the community, we're not going to have appropriate pay. We're not going to get people to actually want to come do this job and to do it really well. So,
And I just want to add, for people who don't know, DCRs are designated crisis responders. So they are the county employees who go out to crises and determine whether somebody can be involuntarily committed or not. And there is a staffing crisis in
we only
many
have
counties.
30 for all of King County. So people decompensate waiting with law enforcement or with the care team for a DCR to come out. Pierce County has expanded who can do this. They have like 400, so we should work on that.
Yeah, or sometimes it's a 2-week wait, and the crisis is right now. So, so I'm Tina Ellison. I'm the Director of Social Services at Compass Housing Alliance here in Seattle. Hi. But I am familiar with Compass. I live in Snohomish County, so I appreciate that. So you mentioned about the closing of hospitals, and we know that Western didn't work, but I think that there's got to be a rich dialogue about what we do, because even in my PSH, we run about 450 permanent supportive housing units, and about 250 of those are for chronically homeless, disabled, below 30% AMI. Mostly the people, I used to work at the Everett Housing Authority for 16 years there, and they're people who couldn't get housed, right? And we don't have anywhere to take or refer people to who cannot be successful in our intensive 24-hour case management modeled housing. Someone probably cost $50,000 worth of damage yesterday, and the only place for him to go is jail or the street. That's not ethically right for us, and we have to figure out what we're going to do about that. And I want to say thank you for recognizing the fact that we pay our social workers, people with master's degrees, under $30 an hour, who make them eligible for our housing, is also criminal. And so I appreciate that you and the rest of the community are hearing that. This is not the good servant job anymore. People have to be skilled and willing to deal with people who are threatening and dangerous, and not because they want to be, but because their illness propels them in that way, and to show compassion to them and show up for them all the time. We have to recognize and respect the work they're doing.
Yeah, you should be on this panel. Thank you. That was really, that was really good. I would just say on the housing question you're talking about, this is all I talk about. I need places to take people. I need low barrier shelters. I see models that work, sites that are beautiful, that are safe, that are well maintained, where there's an appropriate caseload. We just don't have enough, but we also have a 30% vacancy rate. So we can do this. We can do this.
A couple thoughts just quickly around places to go. So you mentioned Western. I mean, the state has been on a pathway to decentralizing Western State Hospital. We've been attempting to stand up 16-bed, 48-bed long-term civil commitment units in communities. Again, we're continue to be met with that NIMBY pushback when we do attempt to do that. Try to turn Western State into a forensic hospital, right? So accepting patients who are referred through the criminal legal system, either found not guilty by reason of insanity, NGRI, or patients who are what we call civil conversions or felony flips. So they were sent for competency restoration and deemed not restorable, essentially, so converted to the civil side. But we have been trying to stand up community facilities. We also passed in 2019, it was actually my Republican colleague's bill, Rep. Schmick's bill, creating different new behavioral health facility types. One of those facility types was called enhanced service facilities, which is envisioned to meet that gap, right? People who need more services than permanent supportive housing, but perhaps don't meet the criteria for civil commitment, and what does that look like? The problem is we can dangle money out there, but we have trouble citing the facilities, and we have incredible trouble staffing the facilities, which gets back to the funding issue that we talked about earlier. And it's not just pay, it is pay, but it's supporting these frontline workers. They're experiencing significant secondary and vicarious trauma, and how do we support and nurture and keep them in the workforce?
We've got to leave it there. Oh, one more question. Okay, great.
Hi, my name is Rudy Pantoja, and I live in North Seattle. I'm a gardener. I work the Aurora Corridor. I work the Crown Hill neighborhood, and I also work Fremont. And my compassion stops when somebody has a sword, a knife, or an axe, and they're chasing me in front of the storefronts because I'm trying to get the tenants, get the properties cleaned up, ready to go for the customers so they can get their hair done, get their nails done, get the chiropractor, do the medical issues. And so I depend on calling 911 on some of these issues. Other times I find people that are have defecated and urinated their pants and they're hanging halfway down, and I called 911, and 911 asked me if they're breathing, do they have a weapon, what race are they, and wake them up, and they snap. So what am I supposed to do, pepper spray them? Or it's not my, it's somewhat dangerous, I just want you to know. And somebody that is in recovery, that's used your social services, that understands it takes time to get to deal with the that craving. Craving doesn't stop because somebody on TV news says we're going to get them treatment and get them started, and things going to be hunky-dory. It doesn't work that way. It's a process. So in my recovery, I've been able to get a hip replacement, heart valve replacement, hernia surgery. My blood pressure is down. The only time it comes up is when I go to the wrong place, to the Columbia Center, and I'm supposed to belong here and try to get here in 15 minutes by bus. And taking the bus from Ballard sometimes isn't the safest thing. And so again, I don't dress for success. I dress like, you know, a gardener. So my question to you is, what do you expect from us business people and the community, and how much compassion do you expect us to have if there's if the street cop says, you know, we want to help, but we can't do it. We can't do anything because there's no place to put them, or they're not interested in going.
Yeah, I'm probably the one to respond to that. First of all, on race, the only way that comes up is if we're looking for who we need to help. That is why we ask the question, what color hair, what are they wearing? So that is important to know. This is where we are. This is how we design the system, right? I'm down 400 officers. I don't have officers to send to calls. I will have 6 cops in a precinct. We are under mandatory minimums all the time. There is violence in our community. I don't have anyone to send. I have just stood up the CARE team. I'm so grateful for the will, the political will, the momentum, the way the city and the county, everybody's moving fast in support of that. We will scale to 24 this year. It's not enough. I'm always the first to say that I can't cover 6 blocks with what I've got right now. And so I'm just gonna keep advocating for who can I send and who's already out in the field doing great work. I just came from Gospel Union Mission. Immediately before that, I was at Salvation Army before that, looking at their mobile crisis. Folks are out there. We're just not using them. And so I need, meaning the city. So I want to figure out how can I deploy these resources so I get people help. Everyone calling deserves a response.
Just to quickly follow up, I mean, so a call with a weapon involved is an appropriate law enforcement response, obviously. I do just want to, I can't help but right size it though. I think part of the problem that I was talking about earlier, why you see people pass by that person in distress when there's someone on fire who is a life worth saving, and it's because of the fear and misperception that is everyone, that the totality of this population is dangerous, and the statistics are overwhelmingly that a person with serious mental illness infinitely more likely to be the victim of a crime than the perpetrator of a crime, infinitely more likely to be preyed on with violence than to express violence or exhibit violence. And so while the types of calls that you were specifically referring to would be appropriate for law enforcement, I think we've got to chip away at and right size that is the minority of the situation. And you know, the greatest impediment, the greatest barrier to people seeking treatment in my professional career is 2 things. Number 1, they don't have hope they'll ever recover, and number 2, they don't believe they're worthy of recovery. And it's that dignity, it's that connection back to society, the removal of the othering, and that notion that radically loving people, that is what actually prompts recovery.
I know we're short on time, but I just have a couple minutes. One thing that I just want to mention, because as a nonprofit service provider, Compass Health has a pretty substantial amount of experience working in this field. And in particular, in Snohomish County, we've partnered directly with law enforcement agencies to co-locate one of our staff with the police department because not only not only are some of the situations unknown for the members of the public, but also for our staff responding, sometimes they're unknown. And those have been extremely successful, particularly with the Verdant Health Commission in Linwood, which funded not only a co-response with the first with fire and EMS, but then also with the police department. And so that was so successful that a lot of these agencies went and then did the work on their own, which is great, right? We gave them that capacity to do it. But I just want to point out that within some communities, they've really figured out how to partner in a really productive way. And one of Compass Health's biggest partners are the law enforcement agencies, because there is crossover. And we figured, well, why not work together in an embedded program versus trying to share information and do our own work, when a lot of the times we're interacting with these same people, and we can do it together. So there are success stories. I just wanted to make sure we end on that note.
We have another great panel coming up, but let's thank our current panelists, Tom Kozaczynski, Amy Smith, and Lauren Davis. Thank you.
Thank you for color coordinating. I did not arrange this, nor did I get the memo. Hell, you too, look at this. So thank you so much, you guys, for sticking around for part 1. Part 2 is going to be great as well. We'll take a brief break for you to have a bio break, do whatever you need to do, and then we're going to come back in 10 minutes sharp and start with our second panel. Thank you. Hello and welcome back to the second part of our Civic cocktail. We just came off an amazing conversation about mental health and how it's being looked at from the governmental and regional perspective. It was a great conversation, great questions. And now we are going to talk more about how mental health impacts BIPOC, how it impacts youth and other marginalized communities. So with that, it gives me my pleasure to introduce our moderator for this panel, Marcus Green, who is the publisher of South Seattle Emerald and Hinton Publishing, right? I got it right. Oh, and a younger Denzel, I was supposed to say. So it's said, it is recorded, I said it. So with that, please a round of applause for Marcus.
Thank you very much. That $100 went a long way. Thank you, Alicia. Yeah, I'm just so proud and glad to be here today. I'm also a columnist with the Seattle Times, and I write quite often about mental health challenges that we're having here in the city, and so this is just a wonderful panel to be a part of. With that being said, y'all can speak better for yourselves than I can speak for you, so if you want to just tell the audience a little bit about yourself, please, starting with Ashley.
My name is Ashley McGirt. I am the CEO and founder of the Therapy Fund Foundation, a nonprofit organization that works toward eliminating barriers to Black healing. We're most known for providing free therapy services to Black community members, but we also have a peer support services program, tuition assistance, a preserving Black family program, because we know how Black families have been torn apart from a legacy of American chattel slavery up to welfare laws that removed Black men from the home and how that has devastating implications on our mental health. We have a youth heal program. We do a lot of work around gun violence. Our community here in Seattle has been hit pretty hard with gun violence. We do a lot of advocacy, just education, training, really working to destigmatize mental illness in our communities, as well as training. I'm a licensed clinician. I specialize in trauma. specifically racial trauma. And I started this organization during the pandemic when everyone was asking, you know, what could we do to help Black people during this time? And I'm like, well, we can help Black people heal and get the therapy. Y'all heard clinicians were making $20 an hour. That's absolutely absurd. And so, you know, most clinicians of color don't take insurance, and there's just a whole host of issues that we're going to talk about today. And that's a little bit about the work that I do that informs the work and the care that I provide as a clinician, as a social justice advocate, and just as a Black woman here.
Amazing. Hey everybody, good evening. My name is Richard Taylor Jr. I am the founder of Taylor Made Empowerment. Through TME, I travel the country and the world over doing keynote seminars and workshops around mental health awareness and suicide prevention. I'm also the author of 7 books focused around mental health as well. Number 8 is dropping in 2 weeks, so I'm proud of that because I'm the kid that never tested well when it came to reading comprehension or writing, and somehow these things happen, right? And so I think that's a testament to when you talk about imposter syndrome and feeling like you'll never be. But that's another story for another day, right? Outside of that, I also host a global podcast called Between the Dream, where I do weekly conversations around mental health, wellness, emotional wellness, and just daily living. I also get the opportunity to serve as the Vice President of Community Engagement on the Board of Directors for NAMI Eastside, the National Alliance on Mental Illness. I know we got some NAMI Eastside family in the house. Thank you all for coming out tonight. And then in my other work, I actually serve as the worship director for the church that is held right here in the Collective. And that is big for me because I grew up in the faith space, and faith and mental health is actually a huge part of my story and my journey. And so really trying to utilize that avenue as well to bring the two together, because I don't believe it has to be an either or. I do believe it can be a both and. And so really working heavily within that. Just a little bit about me. My work in the mental health space as an advocate and what some would call an expert really came from the lived experience piece. I started dealing with depression, anxiety, and suicide attempts at the age of 10. They lasted all the way till 20. 20 was the first time that I actually got a chance to finally seek out therapy. Trigger warning, but it wasn't until my final suicide attempt that almost took my life my sophomore year of college. And so with that, that lived experience piece, knowing how it felt to feel alone, to not have a resource or an outlet at the time, and having to do this all while being a standout athlete in the sport of football, really just kind of messed me up. I was everybody's cheerleader. I was the quarterback of my team, literally. And in that, I could lead everybody else to victory, but I couldn't lead myself. And so in that, knowing how that felt and understanding that so many people feel like that. So I get an opportunity now to work with a lot of corporations, but more so even colleges throughout our country, specifically with our youth and where they are, trying to help them shift from just being aware about mental health, but actually mobilizing in proactive practices that will help them to live a better life.
That one's going to be hard to follow. All right, good evening, everybody. I am Mia Click. I am the Native and Strong Lifeline Coordinator with Volunteers of America, Western Washington, and I just kind of fell into this work. And I do mean that kind of literally. Like stumbled into the BOA and I'm like, I need a job, right? But I had all of this life experience, so I started working at this tribal hub, this resource hub. And my girl's back there, she's a coordinator now. Hey, girl. But so I started about 3 years ago as a tribal hub navigator with no background in mental health at all, just fully off of what I have lived and what I've seen on the reservation. That's it. And that was enough to get me into the door. And turns out they were like, hey, we need a tribal crisis line. Who's gonna run it? This guy. So then I created this program with my older sister, actually, and we've staffed it. There's 25 tribal crisis counselors, all tribally affiliated. There's a reason for that, and I'm sure we will touch on that in a little while. But if we want to get to, the hearts of Native communities, we got to do that with other Native people, right? And I don't care, and most of my counselors don't have a master's. They don't have a bachelor's. Some of them just have their GEDs. Doesn't make them any less valuable. And they are all paid the same because they all do the same work. And that's what I'm here for, and that's what I'm representing.
All right, well, I want to kick us off with a question around, obviously our first panel, I thought they did a wonderful job of talking about some of the challenges as it relates to mental health in the larger community. But, there's a saying that when white America gets the flu, Black, brown, and indigenous communities get the bubonic plague. If you need an interpretation, that means it's something that's bad, and the white community is usually much, much worse in communities of color. And so I want to start with you, Ashley, and ask you, what are some things that are uniquely impacting and affecting our communities of color here in Washington State, that you have experienced?
Well, how much time do y'all have? That's the real question. But the reality is lack of access to quality, culturally responsive clinicians. I went to one of the best universities in the world. I graduated from University of Washington, Harvard University, Clark Atlanta, and they, aside from Clark Atlanta University, which is a historically Black college and university, I was not properly trained in how to provide care to community members who look like me. And so that's actually a problem. And then we have clinicians who are going out into our community providing care to people they don't know how to provide care for, which is the reason I do this work. I actually wanted to be a lawyer, but when I lost my grandmother at 9 years old, my grief turned into major depression. I experienced bouts of suicidal ideation, and I went to a white counselor who did not understand the role of Black grandmothers in families. She, when I told her that my grandmother passed, she's like, it's the normal cycle of life. My grandmother was 62 years old. She was way too young, and she passed away from a stroke. She was extremely stressed out, and we know that Black people disproportionately die at higher rates from strokes and other chronic stress-related illnesses. And so that is why I do this work, because I often wonder if my grandmother went to therapy, if she had another outlet aside from Colt 45, which she drank daily, which was strategically placed in Black communities to kill us. It's literally poison in a bottle. And that was her healing. And that was ultimately what ended her life way too soon. And so aside from studying law, in an attempt to actually help myself and heal myself, because the clinician that I went to in my school, I was educating a grown white woman at 9 years old what it was like to be Black in America. And I was like, there's gotta be other children going through this, experiencing these things, and we shouldn't have to be educating our clinicians. So I went to school. So those are some of the things, lack of access to culturally responsive clinicians, cost, financial burden. We know that people of color have been left out from adequate access to care, and then when we do receive it, we've been misdiagnosed or overdiagnosed. In the 80s, Black men were overdiagnosed with schizophrenia because they were advocating for the civil rights movements, because they wanted justice. Or oftentimes they would present with the same signs and symptoms of a white male who would be diagnosed with bipolar. But guess what? Bipolar is more of the friendly, more manageable, but we're gonna give the Black man schizophrenia. And there's a great book called How Schizophrenia Became the Black Disease. So those are some of the issues in our community, and because we know these things, we talked a lot about Western State earlier. That was one of my first jobs, and we have to talk about the history of Western State, the very land. They perfected lobotomies on Native Americans. And so the history of that and what that looks like, and then I'm supposed to then go out to my community and have them be comfortable providing care. So I'm doing a lot of work to really decolonize therapeutic practices. But there's been so much harm in our system, and then we have to have creative ways, and it's like, okay, you gotta be licensed, and I recognize I am a licensed clinician. I went through the process, and I did all of those things, but I also pay homage and honor to the barbers, to the stylists who have been healing our communities for decades, because that is where people who looked like me went to heal. And they didn't have any training. They didn't have any license. They didn't have $100,000 in student loan debt like me. but they provide healing to my community. And so again, we don't have enough time to really talk about the barriers and how it's really exacerbated in communities of color. Just looking at COVID-19 and what that has done to Black and brown communities, really all of us. But I wonder what the impact of our mental health is going to be. I watched a wonderful documentary called Katrina Babies, and it looked at the individuals who grew up during the time of Katrina and how their mental health has impacted them, how their behaviors has changed, how literally their brains have changed based on experiencing Katrina. So what is going to happen then to the COVID babies and to us who have experienced this? And we're really in a mental health crisis. And we're just now acknowledging things. We talked about the fentanyl crisis earlier, but who has that really impacted? And the reality is, oftentimes until it impacts the white community, we don't recognize it. And so as a Black woman, I have to advocate for the voiceless. And so I stand in this position and I pay honor to Mamie Phipps Clark, who was the very first Black psychologist allowed to practice in the United States, and it is because of her that I'm able to do this work and able to go out and heal my community. But I won't take up too much time because, like I said, it's a lot. I can write a book on it.
That's good.
There's been many books written on it.
Oh, well, Mia, you alluded to it a little bit in your opening statements, but can you tell us just a little bit about what are the unique challenges that are faced when it comes to mental health in the Native American community?
I was talking to my coworker about this driving down, and we were going over all of the things that are impacting the mental health of Native communities. And really, a lot of it is the disconnection from Natives and non-Natives. Because we don't talk about the things that we need with anyone outside of our own neighborhood. And even then, there's a stigma behind that. Because we believe that if you talk about it, you're creating space for it to happen, right? So take all of your emotions, all of your trauma, everything that you've seen in your life, and bottle all of that up and be told by your family, your elders, everyone, we can't talk about this. So then your depression, your anxiety, everything that's bottling up and boiling over, it just sits there and marinates. And it drives us to alcoholism. It drives us to homelessness, to drugs. And that's for anyone. But I think that's going to be the biggest one. And I'm looking at you, Clarissa, because you're shaking your head. So I know, I'm like looking at the other Native in the room. I think that's short and sweet. I speak very slowly. That's going to be another thing that you guys get to know about me. I speak slowly because Natives speak slowly. We keep it short, sweet, slow, just like my grandmother told me to do. That's it.
All right, well, Richard, I know that you work with youth, that obviously there's been a lot of reports and news articles about how COVID, for instance, has and the pandemic, impacted youth, and it's something that parents and families are still dealing with. So, in your experience, knowing that you work routinely with youth, what are some of the things you've seen there?
Oh man, it's been a lot. Nami Isar, we just had our youth mental health conference a few weeks ago, and it was literally outside of me doing the opening speech. It was like youth led the entire way through. So one of the things that we had was this like 8-person youth panel. And in that, towards the end, each one of the high schoolers in the space gave one thing that they kind of acknowledged as a struggle. So comparison was huge, like right at the top of the list. The usage of social media that leads to not only comparison, but the feelings of inadequacy was huge. And I think, too, just the entire time frame that's spent on social media, right? The screen time was one that they brought up that I thought was really important. One student said something that was really interesting. They said a lot of us, they were talking about them as youth, they said a lot of them are like ducks, where you see them on the water and you see half of their body up front and they look like they're moving slowly, but under the water, their legs are just moving super fast. And it's a lot of anxiety, it's a lot of pressure. There are an umbrella of expectations. And so I think with this, what we start to get an opportunity to see with that then is where some of these pressures are coming from that lead to the suicidal rates, the rates of depression that have increased as well. But then also too, they're not, I know that they're young, right? You're talking to somebody who, like I said, for me, depression and anxiety started at 10. I was bullied, and I had my first suicide attempt when I was 10 years old. Like, just like let that sink in. 10 is young, right? And in that, where we are now, that was in 2000. We're in 2024 now. Like, it's even younger now, and it's not an uncommon thing. And I think within this, it got me to thinking about how a lot of times, and I love that you stated this, Mia, definitely when we talk about community, but like the notion of what happens in this house stays in this house, right? I know for me, I grew up in the church, so I was told I wasn't praying hard enough or I wasn't close enough to God. I'm from Chicago originally. My granddaddy's from the South, Possum Trot, Mississippi. And in that, my grandfather is the son of slaves. He watched one of his brothers get lynched, and him and the rest of his brothers fled to Chicago on a train the next day. They knew it was going north. They didn't know where it was going. And in that, I was always told that my ancestors dealt with worse, so I have nothing to be sad about. I have nothing to be depressed about. I got a roof over my head. And so in this, I think one of the things that I'm noticing with our youth now, too, is this idea of provision and monetary provision being somehow this gateway to say that everything's okay. Right? I know they might be young, but they're smart. They're highly intelligent. They're sponges, and they know exactly what it is they're feeling. And so for one of the things that I've been really pressed on lately is not are we just there listening, but are we actually taking what we're hearing and not dismissing it? Right? Because I think that was probably one of the biggest things that I heard that day on that panel was the dismissal piece, whether it comes through these myths that we've heard in our communities for so long, or the fact that just because we are young and haven't lived life, we somehow don't know what it is that we are internally struggling with and battling in those moments.
Yeah. Wow. Thank you for that. Mia, I want to ask you, and just kind of piggybacking off of what some of the things that Richard alluded to, we know that trauma is something that can be passed on from generation to generation to generation. And you can, also the sort of suppression of it in terms of actually, dealing with it head on can be passed on from generation to generation. And so I want to ask you, how does it manifest itself in your experience within our communities?
Yeah, this one's going to be touchy for me, but let's do it. So I will say, I'm just going to, short story, generational trauma is in all of us. Every single one of us. We carry that in our blood, whether you believe it or not. It's in your DNA. Every single one of you. And I see what I am doing wrong and the scars that I carry of my ancestors when my daughter is crying saying I'm being bullied and I feel this way and that way, and I kind of pass by her room like, are you good? Are you good? She's crying. She's like, yeah, I'm good. And I just keep walking. And I have to stop myself and go, oh my God, that's me being scared of the other answer, because we can't talk about it. We can't talk about it. It leaves space, and I'm scared for my daughter, but I'm more scared for me. So I myself am trying to break this cycle that we are all in. And I know, damn well I know, that I am not breaking it, but I hope to God my daughter does. I hope to God. But it manifests just like that. It wears on us, that weight of carrying those scars, trying to heal something that you didn't actually go through, but you can feel it every single day. So it manifests weight and it put me through depression very early on. In 30 days from today, I will be 12 years clean.
Congratulations.
Thank you. But it's just that, like I was saying, drugs, alcohol, that's not us. We're being driven to that because that's all we know. Because we weren't taught how to cope because our mother wasn't taught how to cope. Her mother and her mother before her and her mother before her and so on and so forth. We don't know what the hell we are doing. But we're trying to figure it out. And in a community, like a Native community, not talking about it, like I said, it's just bottling it up. And that's why we have a tribal crisis line being answered by tribal people, right? Right? Because they need that connection. Because they want to call and say, hey, I can't talk to my auntie, whom is raising that child because their mother couldn't. Mental health.
Yeah. I got to say, there's a Swahili saying that says, women hold up half the sky. And I got to say, Mia, between you and Ashley, y'all hold up the other damn half of it by yourselves. I mean anyway. Well, Ashley, I want to ask you this question. A couple years ago, I did a Seattle Times column. It was writing about the intersection of law enforcement and mental health, particularly in communities of color. And I brought up Charlena Lyles. She was a mother who was experiencing a mental health crisis and ended up being killed in an interaction with police. In the article I wrote about, I'm somebody who lives with bipolar disorder. I wrote about having a breakdown in the middle of downtown with my mother, and she chose not to call the police because she was scared what would happen, if they came. And so I want to ask you, I just want to ask your thoughts about what is that collision and what does that look like in everyday life when it comes to law enforcement and mental health?
It's a very real pain and complex issue that so many Black Americans deal with when it comes to seeking help from law enforcement, but also knowing what that help has looked like when we've reached out to law enforcement for help. So many of us had found ourselves at the end of the barrel of a gun, like Charlena Lyles and like so many others. I come from a family where my great-great-grandfather was the very first Black sheriff in North Carolina, Fayetteville, North Carolina. So I have a history of police officers in my family, but I also hear of the stories of George Floyd, Eric Garner, all of these instances where we know that the police has harmed our communities, or where we've been over-criminalized for mental illness instead of having a social worker come out or a clinician. But then we have individuals like Dylan Roof, where he was said that he was mentally ill and he was taken to Burger King, and he received, 5-star treatment from law enforcement. Why is it that people who look like me do not have officers take them to Burger King before they're arrested? And so it's a very real disparity in our community, and the reality is officers just aren't trained. They do not have the clinical skills, and I know we're doing a better job here in Seattle. I work really closely with the Seattle Police Department. I was just at a community safety event with the Mayor, Bruce Harrell, and a host of Seattle police officers who are really working hard in trying to change these things. But even I personally, I don't feel comfortable calling the police, and so I'm gonna do everything that I can with the resources that I have in my community to seek help before I dial 911, because I know that I may not see my family again if I call them. And so that's a very real fear, even coming from a family who has police officers in the family. And so we really have to talk about that. What criminalizes one community and what gets another community treatment? And where are those barriers coming from? And the reality is it's systemic racism. And we have to do a lot of work to, address our biases, work to be becoming anti-racist, and all of the things in our community that we're just not there yet. And so as a people, we have to come together and help ourselves, and also get, social workers, paired up with officers so that we don't have to call 911. There was a gentleman who spoke earlier and said, he's calling 911. The police are asking him all of these questions. He doesn't feel safe. He has to be in the position to put himself in potential harm's way dealing with a potentially mentally ill person, and that's just not okay. We don't have enough resources. We don't have enough funding, and then you're asking us to do this job for $20 an hour with $100,000 in student loan debt? Absolutely not. That's not okay. But the reality is, there's so many changes, and we have to have more conversations. And I was blessed to be in a room yesterday where we had community members talking with police officers and also holding them accountable. How can we hold you accountable, and how can you show up in our community so that we know we're not going to be harmed by you when we have a legacy of literally being harmed by the police? And I know that other people don't have that reality, but for a Black woman in America, a Black male, a Black person, trans, however you identify, non-binary, and other persons of color, we just haven't had a good history with policing, and we have to ask ourselves why. Well, after slavery ended, it literally went to mass incarceration, Jim Crow laws, all of these things where we over-policed our communities. We strategically had police in Black communities, and again, it deterred our families, separated our families. So the history of why is policing the way that it is, and what happens when you put on that uniform. The Stanford Milgram prison experiment that really looked at that and addressed, they were looking at studying evil. And if you're not familiar with that study, it was a random trial, like a group of this half on the left, you all are assigned police officers. You here on my right, you all are the inmates. And so what happened when they put these individuals in the room, those people who became police officers, they started beating them, sodomizing them. And it was something about that uniform that really turned them into something evil. And so how can we really address that, and how can we get individuals who hold that badge and take that uniform to not go out and abuse others? But there's something about when we're in a position of power, how we abuse those who don't have power. And these weren't even people who were really police officers. They weren't even really incarcerated. The study barely went 2 weeks. There's been multiple movies made on it. And so it's a very real thing that's happening in our community when we look at the criminalization of mental illness and who's really criminalized by mental illness.
Well, Richard, I want to ask you a question before we do get into an audience Q&A. I was recently listening to a podcast, and I think it was Esther Perel, and she said vulnerability isn't you just spilling your guts out and being, and expressing, your whole full truth. Vulnerability is the ability to tell your whole truth and feel comfortable, feeling that you're in a welcoming, belonging environment where you're not constantly judged for, telling that truth. And so you had said earlier, you talked about your own journey of some of the things that you had been through, some of the challenges you had faced. And we had talked earlier about, you having that stigma for so long when it came to dealing with mental health. And so I want to ask you, how do we continue to create spaces, whether it's in our everyday, whether it's at work, in our friend groups, our family groups, how do we continue to create space for that vulnerability?
That's a great question. I think before we can create the space externally, we need to do heart checks internally. And the reason why is because I feel like sometimes bad things can happen from good intention, right? And so we want to make sure that we're being careful with this, because we have a responsibility. Definitely now more than ever, because of the fact that therapists and clinicians are so overworked and the demand is completely outweighing what's there. And with that, one of the things I've been doing is working with folks, therapists and clinicians from around the country who have been trying to take a deeper look at community-based mental health support. So I love it. You talked about barbers. You talked about stylists, like individuals who, I got a good friend who runs a program called the Confess Project, and he literally goes around the country training barbers to be, mental health first aid certified, to have these conversations, right? And so it's not just on them, though. It's all of us, right? Because, and I love that you do this with your staff. You don't need to be a professional to be an individual that cares enough to take the time to really lean in with people, right? But it's us looking beyond ourselves, our busy schedules, our biases, our own privilege, We talked about the story earlier about driving by with the lady on the highway, right? Like, we have to look at ourselves and ask those questions, why? But then also, too, starting to figure out what we need to do to shift that. I think for me, vulnerability, I've stopped caring about what people felt a long time ago. Because here's the reality. Nobody can tell my story better than me, right? And I think in that, it's the same for all of us. Each and every one of us in this room has a phenomenal story, right? Some of us, it might look like this, or it might not be as dramatic, but it doesn't take away from the impact. And I think within this, we need to take a deeper look at ourselves to be able to express that vulnerability, but then also to create that space to where we're being consistent with it. When I was in Chicago, I got an opportunity to work with a bunch of mentoring programs throughout the city there. And one of the things that we noticed was that when we were consistent, so were the young men that we were working with, right? And I think that this is where it really lies for us. It's not just going to be the share the story one time and that's it. It's actually going to be after we share the story and we create the safe space for you to do that, how do we now start to move to help when it comes to bridging from hope to actual healing, right? And so I think with that, vulnerability is wildly important, and it's something that I'm going to continue to push. I think that we need to look at ourselves, though, within that. And also, too, it's not just for the individuals that we're trying to help within the city of Seattle, within Snohomish County, within Pierce. Let's take a look at our own families. I just lost my brother to an overdose who dealt with schizophrenia literally a month ago. I was walking into the collective right here, and Alicia saw me, and she knew something was wrong. I got the call as I was walking into the door. And in that, I know I did what I could, but I still wrestle with was I vulnerable enough? But it got me to thinking, even though I couldn't help him, what am I doing to make sure that I'm staying on top of being able to help the other people around me? Those that are not only willing to hear and listen, but those that just might need a text message or a phone call to let them know that you care, right? And so when we talk about this, creating the space doesn't just happen within these realms of our work in the nonprofit space and what we're doing there, but it starts at home. And more importantly, it starts at the home here, because if we do it here, we're going to be true to ourselves enough to do it for others. And so I think that we need to look at internally first.
I gotta say, as somebody who's an agnostic, I've never said amen so much in my life, so thank you. But with that, we are gonna open it up to the audience.
Tara. Hello.
Hi, I am not typically a question asker, but I have been on the literal very edge of my seat pointing to you the whole time. And so I don't really have a question. I want to stand here and bear witness. As a daughter, a sister, an auntie, a mother, a grandmother, a woman entering the auntie era of their life, I want to bear witness that you are the salvation of our collective people. That silence, that shame has held us down, and my parents' generation couldn't do different, and my generation didn't know how to do different. And I sit here listening to you three saying, like, this is the hope of our salvation. So I thank you. Continue to stand in that gap. And just because you don't break all the curses doesn't mean you didn't break any of them, right? So thank you.
Well, I want to thank you all for being here. It's very enlightening. I want to talk mostly to me about childhood trauma and what are your organizations doing to support young families to hopefully minimize some of this trauma.
So I'm just going to speak for my program and what I do. Or not even what I do, but what tribal programs do. And so we go out, we table, we go to these events, we talk to the youth, see what they need. I know Clarissa's standing right here. Clarissa, so in the tribal programs, we actually have the hub that just trained and starting positive Indian parenting, which is extremely exciting. I know that that's, everyone's like, all right, no, seriously, it's real. So we're gonna start there. But we talk to youth, we have youth call us all the time. We do everything that we possibly can to reach those kids and let them know this is safe, you know? Because again, it's not safe sometimes at home, and just opening that space for our youth and going to schools and talking to them and say, hey, this is what we're gonna do. I know you're Native, I know your culture, I know your mom said we're not gonna talk about it, but this is a safe line where you're gonna call in and you're gonna talk to an auntie or an uncle that they wanna hear it, they wanna hear your voice, and just giving any youth that safe space, it gives them that hope that they need to not veer off, you know, like so many of us have done.
I was just going to help her because that's more along the lines of my program, but I wanted to be able to help her, but she did it. I don't even need to say anything, but while I'm up here, I just want to thank you guys for being vulnerable and really just sharing your stories and your passion with us. I know that it's hard to do, so just thank you so much for being here and being a part of this movement.
Hello. So as a mother with 2 young boys, and I see them treading water, and you've talked to those young boys, what advice do you give to a mother to support them?
A few things. I think the first is to show yourself grace. So important, because I think that we want to be everything that we can for our kids. And the reality is that that's not always the case. We are who we are, but understand that the seeds that you're sowing are making a difference. One of the things that I have noticed to be a huge help with mothers and parents working with their children has been taking things back to the basics, right? So obviously, we're in a very distracted society now. But something as simple as, family meals, whether that be on a Sunday or at some point throughout the week, bringing that connection back into the space. I think, too, realizing that even though they're going through that transitional phase right now where, of course, the testosterone is bursting through the roof and, oh, Mom, I don't need you right now, or whatever it might look like in that situation, when the rubber meets the road, I'm not just going to say they, we look back at those moments in our darkest times and in our hardest times of those little glimmering lights of hope. And it's the nurturing piece that you carry as a mother. It's the I love yous. It's the moments where you speak to their character traits and who they are, right? Where you lift them and build them up, and they might not see it right now, but you're always sowing a seed. And the reality is that there are going to be other people that they meet and connect with that will align with everything that you are pouring into them right now, which is why it's not your duty to always have to be everything for them. And I just want you to be encouraged in that you're doing enough, you're doing well, but in that they have their own process that they have to be able to run and work through. And I believe that over a due time, you'll get a chance to see all of those great fruits come to life. So keep up that work with that.
All right, and final question for you all, because I know somebody came up to me earlier and they said we go to so many of these things and we leave without an assignment. It feels at times like a pep rally. And so I want to ask, other than, of course, getting your book, Richard, in 2 weeks, and financial donations, Mia, to the hotline, and some financial donations to the therapy fund, Ashley. Did I plug them all? Did I plug it all? Okay. What are some things that people can do and take away with them, back outside to the real world once they get out of here?
I would say to continue the conversation. We don't have enough conversations about mental health, and there's someone sitting in a dark corner with a bottle of pills right now. I've been that person who doesn't want to live, who doesn't want to go on, and they don't know that maybe you felt that way too, that you've experienced some things in life. And we don't talk enough about how life has been lifing and how we've got through those bouts of life. So I think it's very important to share our story. And, you know, even if it's posting on social media, hey, I was at this conversation and we talked about mental health. It's Mental Health Awareness Month. Calling a friend and just talking openly and candidly, showing people what you do. You asked, how can you support your children? And I echo everything that was said, but I would also add, show your children how you receive support yourself. Because I never saw that from my mother, from my grandmother who raised me. I saw the unhealthy sides, how I talked about my grandmother drank a lot. And so I would love to have seen how my grandmother or my mother seeked support in other healthy ways. So I think that's important as we go throughout this day and throughout this world, throughout these weeks, throughout these years, is to show people, how are we seeking support? How are we caring for ourselves? How are we caring for our mental health? And what do we do on bad days? Because, you know, it's okay not to be okay, but just not stay there. So how do we show that we don't stay in that moment? And how have we got to where we are? If you have been a person like myself who's experienced suicidal ideation, and what does that look like? And how do you show your community? And sometimes it's just sitting next to someone. And, you know, being comfortable sitting in the darkness with others. We're so prone to fixing things in this society, we want to turn the light on. But sometimes we just need to sit in the darkness and get comfortable with the darkness and ask our own selves, why are we so prone to turn that light on? We don't have to fix everything. You don't have to have the skills or the know-how, but sometimes it's just sitting in the darkness with yourself and with others so that we can get to the light.
I love that. Two quick things. The first is that I would definitely encourage us to up our empathy, right? We might carry it. Some of us don't. If we don't, I want us to really take some time to consider, like, what does that look like for me in my life? Dr. Adam Clayton Powell Jr. Did a speech back in like the 60s, and it was called What's in Your Hands. And he uses examples from like real life and Bible. He talked about Moses, who had a speech impediment, but he was able to lead a group of people. David with a slingshot fighting a giant. But in this, though, this idea of what is it that you possess in your hands that could make a change in the lives of people? For some of you all, you carry a grace gift or a mercy gift. For some of you all, you sit in positions of power and you have an opportunity to create space at tables for people. For some of you all, you are an authoritarian where you can literally line folks up and galvanize people. Whatever it is, I want you to really consider when we talk about mobilizing, right? Because the conversation is one piece, but the conversation is going to have to move to some kind of legwork. What's in your hands that you possess that could really start to be a positive gateway for the people around you and the people that you're connected to?
Just awareness, right? Be willing to learn things that you know nothing about. You are going to be extremely uncomfortable in these spaces that you have never been in. Good. Sit in that discomfort. Get comfortable with that discomfort. That's how we learn. That's how we grow. And yeah, if you don't have empathy, figure it out. Learn it. It's hard for me to teach it, but if you sit down with someone that is in a crisis and you don't feel something, well, you're not human, right? But you got to sit there and be uncomfortable in all of these different communities that we don't all share, and listen to what they need. Listen to what is working, what's not working, what they need. And then I want you to get pissed off and then start advocating. Get loud and get angry and start advocating for the people that do not have a voice, that don't have a microphone, that don't have a stage. Start advocating for them. You don't have to give money, but give time. Give your love, give hope that someone there is willing to reach out and listen, because that's all we ever need. We just need someone there that gives just a tiny bit of amount of care. That's all we got to do. Just love each other. Take that out into your own communities.
Well, thank you is not enough for all that you shared today. but it's all we have. So thank you so very much. Can we get another round of applause for our panel?
I am moved tonight. I mean, I'm moved after all of them, but this tonight was really great. And I think we are all in community together tonight and in the feels. And I'm not a feels person, as Richard can tell you. So thank you so much. And I do have homework assignments for you all. So first, I just want to say thanks again to Comcast, Bermudez Media, and the collective for being great hosts and partners with us tonight. Something that you can do tonight, or well, you do part of it tonight and some next week, which is share what you learned tonight. Share it. Don't let this just be something that sits here. You know, one of the things we just recently did is that most of you probably got our resource guide that talks about this topic. We also have it on our website now, along with other guides that we have. We want you to use this content and share it. Use your networks, use your channels to share this information. We have one more Civic cocktail before our summer break. So our one that we're going to do on June the 5th, right here at the Collective, is focused on something I think we can all get behind, which is called breaking barriers. We are going to talk about how to communicate with each other across political barriers, plural. Plural. So we're going to talk about that. We got great speakers coming out, great activity that we're going to do there as well. So come prepared to have a little bit of fun while we talk about crossing and bridging those political divides. We also actually in the middle of that have a special event. So City Club is partnering with LISC and the Housing Development Consortium for Affordable Housing Week. So on May 15th, right here, we're going to have kind of a special Civic cocktail-ish discussion around affordable housing and FIFA. Believe it or not, we're going to talk about how affordable housing can pair with major sports and what could happen with some of those temporary housing to hopefully make it more permanent housing for those residents that need to have an affordable place to live. So tickets are available on our website as well as the one for our June 5th cocktail. So again, thank you again. And again, this programming would not be possible without all of you and the financial support that we get from our partners. A little bit from ticket sales, not a lot, but if you want to donate, please feel free to donate to our organization as well. We want to remain sustainable. We want to be able to continue to bring this programming so it can be accessible to everyone, not just those that make a little bit of change. So with that, thank you so much. Thank you to my staff again for taking such good care and making sure that this programming came together tonight. So we'll see you hopefully maybe in a couple of weeks, if not definitely next month. Have a good night, everybody.